Hi everyone, my name is Alicia and I'm going to be covering fall prevention. This is important to me because in nursing practice, fall prevention is something we deal with every day. But as a long-term care facility nurse, I feel like it is day in, day out, something that weighs heavily on me and that I have noticed so many different things that we can implement in daily practices to enhance lives for ourselves and for our residents. So this project, I'm going to discuss the problem with everything falls, but mainly with our geriatric population in long-term care. I'm going to discuss some quick facts regarding falls, the effects on both residents and our nursing practice, a literature review, which is going to include 8 articles, all evidence-based, peer-reviewed from nursing and medical journals. These are kind of the bread and butter from where I'm getting my information for proposed changes. So all are tried and true and evidence-based. I'm going to discuss a proposal which will include 3 probable interventions that I would like to implement on our units in the long-term care facility for a 1-month trial. All interventions will cover, how we're going to implement them, who's going to enforce them, and then how are we going to gather results to see if these were effective in decreasing falls. Lastly, I will cover the conclusion and my references used. So the problem is falls are occurring in our long-term care facility about once every 2 days. A few months ago, we had 2 fall-related deaths just in a couple months of each other. Of course, that's the most severe injury, but other injuries can be hematomas, lacerations, head injuries, fractures, sprains. Head injuries cost the patient, most of the time a direct ER visit because we don't know, what the injury is, the extent, because a lot of these geriatric patients are on blood thinners. So all injuries, can range in severity. Right now in my long-term care facility, we do not have preventative measures. Our measures are mostly post-fall interventions. We have adaptive beds, fall mats, bedside bean bags, all diminish and decrease the level of injury that are going to occur, but none of them proactively decrease and prevent the falls from occurring in the first place. We do use call lights, but this is not a universal prevention measure because not all residents can use them. If you have any cognitive impairments like dementia, you're not going to use a call light. And then if you have physical inabilities, you're not going to be able to use it, like a neurodysfunction, things like that. So it's important to implement some fall prevention strategies that aren't relying on residents to do it, but kind of put the responsibility back on us as nurses to ensure the falls are being prevented. So some quick facts. Falls in the United States, about 1/3 of long-term care facility residents suffer a fall each year. Of the third residents falling, about 10% of them result in serious injury. And serious fall-related injuries accrue about $14,500 in healthcare costs. So not only is this negatively impacting their physical and mental states, it's also increasing their healthcare costs, and it's decreasing their abilities to perform ADL. So they're having to go into long-term care facilities earlier, getting rehab, things like that. So there's no positive effects of falls. So why is this important to nursing? As nurses, our responsibility is to promote and enhance quality of life, promote patient safety, and falls negate this. And due to our direct contact, our immense direct contact with these patients, responsibility kind of falls on us. And it says in this bullet point altogether, falls have been used as a nursing sensitive quality indicator since 1999. So this directly tells us that our quality of care that we are providing is measured by many things, but one of them being fall prevention. So if we are allowing falls to happen on our watch, this is, not good for our nursing practice and how we are being measured. In a study, and we can talk about this in the literature review a little bit more, but nurses and UAP assisted personnel were being interviewed, and they said that due to the negative effects of falls, administration was intensely messaging them, pressuring them to decrease falls. So they felt the pressure and they voiced feelings of increased stress, guilt. They doubted their practices. They felt liable. So not only does this negatively impact our patients, but it impacts our practice and who we are and how we feel about our profession. So addressing falls is important. So as if it's not evident that we need to change our practices and be diligent about preventing falls, I thought it was important because a study was performed and it showed that just by preventing hourly rounding alone, falls in a long-term healthcare facility were decreased by 50%. They were meeting patient needs, ensuring safety, and decreasing the occurrence of preventable events by proactively addressing problems before they occur. By meeting these needs proactively, call light utilization was decreased, quality of care and patient satisfaction increased. So my rationale for practice change is if we can implement just one intervention and it decreases 50% of falls, what's going to happen if we just slowly implement 3 interventions into our practice? How low can we get this fall rate? And also, we're busy all night as a night shift CNA or nurse. A lot of people think those in the long-term care facility sleep all night. That is not the case. We are busy helping our CNAs address call lights. If we are rounding on our patients already, if we just take a few extra minutes to address their needs, the call lights aren't being utilized as much. So we're better able to utilize our time elsewhere. So to start the literature review, this one's Preventing Inpatient Falls, the Nurse's Role. So it discusses the impacts of fall, patient-related factors, prevention measures, post-fall interventions. So this article is very full circle. It discusses why do falls occur, what happens when they occur, what can we do to prevent them, and then what can we do to address them once they occur. So it is really important, and it shows a little piece of information about everything, all fall related. It also discusses centralized video monitoring, which is not really applicable in long-term care because due to decreased staff and limited funding, it's not feasible. And it also encroaches on their rights because in long-term care, that is their home. All of the interventions discussed were evidence-based. Specific things discussed were hourly rounding, shift huddles, and increased staff communication, which is important because these are some of the concepts going to be discussed in the proposed interventions later on. It also says suggests that call lights were ineffective when used by themselves, which we've discussed. Some patients can't use them, so if that's your only preventative tool, you're going to have falls. They're not going to be prevented. A drawback to this was it was not related to long-term care, but a benefit of this article was that it's supported by the Geriatric Society. So they promote evidence-based practices, and it is geriatric driven. This one is initiating and sustaining a fall prevention program. So a trial was performed in a 188-bed hospital facility. Their fall prevention program was revamped after they were seeing that fall rates were increasing. It was found that the fall prevention team was no longer a thing. There was low staff morale. Staff was not educated on fall prevention measures, but by revamping that, improving education, and improving staff communication, along with some staff incentives, fall rates decreased within a year. So this was an important article because it shows that we can throw all the interventions at preventing falls that we want, and they might be the best, but if staff is not communicating with one another, and if morale is low, none of them are going to be effective. This is an article, All Things Purposeful Rounding. So this one introduces the 4 Ps, pain, potty, possession, and position. It discusses that the 4 Ps, addressing them is going to be your ticket to preventing the most falls because falls typically occur from one of those 4 things. So if we're rounding, we need to make sure we are not going into a room and just looking at them to make sure they're in bed, but addressing, what are the signs of pain? Are their belongings close to them? Let's offer to take them to the restroom, and maybe they need to be repositioned. Maybe these residents are attempting to get out of bed to do some of these things. This was medical surgical driven, so the data can't be directly compared to long-term care because the comorbidities and ages and chief complaints are a little different than those in long-term care. But the benefits to this article was that patient safety and staff communication and patient and staff communication were all improved by performing shift huddles. So not only are we preventing falls, but we're bettering our practices and promoting patient communication. We're giving them an incentive in promoting their activity in their own care. This article is Complications and the Socioeconomic Effects of Falls. It's specific to the elderly population, but it is a questionnaire for community dwelling residents. So the drawback to this is they're community dwelling, so they're living at home, whether dependent or independent of care. And the questionnaires are reliant on the memory of those participating. But it explores the coincidence, characteristics, and complications of the falls. So this article said that most falls occur in the winter. They mostly occur at night, and they most frequently result in sprains and fractures. So it's kind of important as a night shift nurse, to me, we have the fewest resources at night, and that's when most of our falls are occurring. So that was really interesting to me. To prevent falls, we have to be knowledgeable on, what are the most common causes, what are the most common effects. So this was a great article for that. But it was more than 70% of those over the age of 60 experience a fall. And of course, it represents a great individual and economic burden. So prevention measure is a key concern here. This is safety standards, implementing fall prevention interventions and sustaining lower fall rates. So quarterly fall rates were reviewed in an inpatient rehab facility. They implemented, this was before and after they implemented shift huddles, signage, and hourly rounding. It was found that hourly rounding was the most effective tool in decreasing falls, but it doesn't say why signage and shift huddles were ineffective. I'm guessing they were not performed correctly, but I thought this was interesting, and it does talk about 2 of the 3 interventions I'm going to discuss a little bit later. The thing that I would like to change about this study or change in the way we are going to implement some proposals on our facility is that this study was directed more towards clinical nurses, nurse leaders, and nurse educators that did not involve assistive personnel. And, those are our feet on the ground. They're getting to these patients when we aren't. They're addressing more of their ADLs and their basic needs. So they're important to recruit in this fall prevention program. This is long-term evaluation of the implementation of a large fall fracture program. So pretty much the fall rates or fall programs in Germany, over 1,000 long-term care facility programs were started like 2007 to 2010, and 10 years later they were evaluated and found to not be successful. They weren't successful due to high staff turnover, reduced fidelity in training, or change in priorities. So while we can't prevent as much as nurses this high staff turnover, we can ensure that in-services and education is constantly being provided to ensure that all staff are on the same page in fall prevention, and we're all doing what we're supposed to be doing to prevent these occurrences from happening. I also thought it was interesting that Germany, the reason that their fall prevention standards are still being implemented, they might not be as effective because education's fallen at the wayside, but they're still being implemented 10 years later because they've been mandated since 2009. Germany thinks fall prevention is important, and it should be. And the gaps here, the strategies were limited to documentation exercise, environmental adaptations, medication reviews, and hip protectors. So the interventions I would like to discuss are not really included in this study. So this article discusses all barriers to hourly rounding. I really liked this study because you can't propose interventions without being proactive and knowing a little bit of the background. I want to know, why didn't it work? If hourly rounding has been utilized by other facilities and it didn't work, it's giving me a leg up to know why it didn't work. So before we implement it on our long-term care unit, knowing why it didn't work, maybe we can fix some of those barriers. We can address them before they occur. So key issues found included poor staffing workloads, lack of education, and patient acuity levels. These barriers were not perceived by administration staff, but by frontline staff that's dealing with it day in and day out. So Understanding the barriers before submitting a proposal allows us to formulate possible solutions to address concerns before they happen. So this was a really neat perspective of this article. So in summary, the literature varied from prevention measures to post-fall measures, and even discussed the effects on not only the geriatric population and patients, but healthcare workers. I don't feel like the negative effects of falls that it has on healthcare workers is discussed very frequently. Key points, most articles included studies from inpatient units, hospitals, med-surg units, rehab facilities, and were not really long-term care focused. So comorbidities, chief complaints, all of that can vary from acute care to long-term care. Many articles presented shows that effective rounding is awesome, that it works, it's most effective, and that call lights aren't really effective when used alone. Purposeful rounding, shift huddles, and call lights were all going to be discussed as part of my proposal, and they were, all discussed and proven to be tried and true when implemented correctly in the literature review. Let's see. My proposal is I would like to decrease falls by 50% within 1 month during that trial period, utilizing purposeful rounding, shift huddles, and mindful room assignments, while also utilizing that one intervention that we have, call lights. So we've said that call lights are ineffective by themselves and that shift huddles or purposeful rounding is the best. So why not combine all of these interventions to decrease fall prevention as much as we can within a 1 month time frame? So my first intervention proposed is purposeful rounding. So instead of putting all the responsibility on nurses, the CNAs are rounding also. So we want to round nurses on even hours and CNAs on odd. And again, instead of just looking to make sure they're in bed, we want to address the 4 Ps each time. And then we want to track it on whiteboards. I'm sure you've seen, like on med-surg units in the hospital, they have the whiteboards and then the ribbon at the bottom for signatures hourly. So to track the implementation of this, when you go in to address these patient needs, we put the eyes on the patients, we want to initial on the hour. So this holds us accountable. And then each morning, the unit supervisor can ensure that this is being completed by looking in these patients' rooms to make sure they're being filled out. So we're wanting to address the 4 Ps and to hold ourselves accountable, initial each box, and make sure this is being done to prevent the falls. Shift huddles. So before each shift, nurses are to gather their CNAs for the shift, facility aides, all their UAP, and discuss in a brief meeting before the shift starts, discuss who's high risk, did any room assignments change, prevention measures that are specific to each patient, and then current resident needs. So if 125A got all of their teeth extracted today, we want to discuss their diet. We want to discuss maybe their pain, what to look for, and what to relay back to the nurse, and how to address each of these patients individually. Each person, we want to provide personalized treatment, and we want our CNAs to be knowledgeable on what is going on with our patients. While we're doing this, we want to utilize the huddle forms. So when the huddle is completed, this will include information on what we're talking about, what's important, what to include in these meetings, and then they're to be turned into the supervisor mailbox at the end of the shift. Shift huddles are the responsibility of the nurses, so it's the nurse's responsibility for that unit to gather their unit CNAs and discuss the important things in a brief meeting. Mindful room assignment. So this is already being done to a certain extent, but there are a few rooms and more patients, so it's easy for fall risk patients to fall at the wayside. So we want to bring back all the fall risk patients and put them close to the nurse's station. This includes those with a previous fall history. And instead of all of this being, falling on the ADON, DON, and administrators' shoulders, we want to incorporate the opinions of our clinical nurses because they're the most aware of what's going on with these residents and who would benefit most by being closer to the nurse's station. So we want to incorporate their opinions in these room change assignments. To track results, we want to be sure to educate our nurses to document the falls. we want to compare the documented falls within the 1 month trial period to those the 1 or 2 months prior to using these new interventions. We want to compare them to when we were just using call lights and see kind of, you know, what we're doing. So the baseline fall rates from the month prior are to be compared to the trial period. And then per results, of course, changes are to be made with staff input, but at the supervisor and director's discretion. So in conclusion, the elderly population is at the highest risk, which is why I'm so passionate about it. This is a vulnerable population. You or I would bounce back a lot quicker if we were to fall than some of these elderly residents. They suffer debilitating issues after they fall with, you know, more severe injuries. It's imperative to establish fall prevention measures and long-term care to promote patient safety and maintain healthy quality of life. These are both, you know, responsibilities and promises that we made when we started the nursing profession, was to, you know, do the greater good, promote our patients' health and safety. And then fall prevention programs utilizing multiple resources simultaneously can decrease falls by 50%. We're going to include hourly round shift huddles and mindful room assignments. Research has shown that they can decrease the rate of falls, fall-related injuries, and promote patient independence, encourage teamwork, and decrease healthcare costs. So there's really no harm in implementing these 3 proposals because they take a little bit of time, but they have no extra costs associated with them. So if we're seeing that they're beneficial, let's use them. Let's put them to work. So if you have any questions, feel free to email me. This is, again, something I'm passionate about. I've done a lot of research on it. It's something that I think about while passing meds and being on the med cart at the long-term care facility. And it's something that, you know, I've thought long and hard about, and what ways can we remedy this problem. So please reach out if you have any questions. These are my references. All 8 references are mentioned in that literature review. I hope you enjoyed the presentation and it was informative.